If you're one of the thousand of employers last year that saw an explosion in your healthcare cost, well, you might be asking yourself a simple question. Can I just buy care directly? And probably one of the most common questions that I get asked is, can I just contract directly with a hospital? And the answer, if you're an employer, is yes. But as you might expect, it's more complicated if you want to build an entire network. Sure, you can get a simple hospital contract. You might can contract with a physician group. But to do that on scale, well, it's really hard. And let me show you why. Thought I'd spend a little bit of time walking through that very complicated process today. So, building networks, well, it's just hard. It's hard for a lot of reasons, but probably the biggest one is that there's just a lot of individual contracts to execute. In Texas alone, there's probably close to 500 hospitals. I have no idea how many physicians there are, but probably close to 50,000. Now, many of those physicians are in groups, but probably that group nature just actually makes it more complicated to actually execute the contract. So most of these networks that are built today, they've been around a long time. These relationships have been established and the rate structures have, well, slowly eased up over time. They've gotten larger, as you can expect, and actually more expensive. And so building these kind of contracts at scale is just really, really hard. There are some things on the horizon that's going to make this easier, and I'm going to show you a little teaser at the end on how that could happen. But in the interim, it's just a difficult thing to do. And as someone who's built networks in the past, I can say it's even gotten more difficult today. One of the biggest challenges in building network contracts is the fact that these relationships have just gotten more complicated. For instance, now you have hospital employed physicians, where in the past, hospitals really function on their own contract. You've got doctors and physicians in very large groups. In fact, there are anesthesia groups in Texas that are just huge. And today, even groups span multiple cities. So you can't really pick and choose which providers you actually want anymore. It's just not that simple. If you want, say, certain physicians in a contract, you're probably going to get all of them if they're employed by a hospital. And that's true if they're employed in one of these larger groups too. You might think that would make it easier. And from a contractual standpoint, it might make the paperwork easier, but it's actually more costly because these groups are going to have larger leverage. This is particularly true by hospital employed physicians. And that's because hospital contracts, on average, are going to be more expensive than, say, a wild type physician contract. That's one of the reasons that employers have seen such an increase in cost as physicians have become employed in these relationships. The second thing is that leaves a lot of onesie-twosie contracts. So now you end up finding yourself in a very inefficient build of putting a network together. And probably one of the most surprising things that's happened in the last decade, at least for me, was the idea that there's just physicians that are completely untouchable when it comes to contracts. And those are physicians in groups that are called concierge docs. Most of those physicians do not take insurance. And if they do, it's often in somewhat of a modified way, meaning they're going to take your insurance for hospital, but you're going to have to pay on top of that. It's really hard for employers to actually build a network around a universe of concierge physicians unless you get into the realm of direct contracting, which we will talk about in a future video. The second thing you run into is this concept of just physicians who just refuse, period, to be in any insurance contracts. And there's a growing number of those physicians today. So it's just incredibly challenging to build a network of docs today that can be leveraged at scale for an employer. Now, I hear all the time that there are groups popping up that say, hey, I can offer you a much lower rate. All you need to do is jump into our network. And when you look at the numbers, you'll often, as an employer, see something that goes, wow, this actually looks like a good deal. But one of the challenges that you run into in network contracting is that specifically related to hospitals, hospitals will provide a low rate to anyone if they don't have any patients in the network. I'm often reminded many, many years ago, a hospital executive in Dallas, I went to him and I said, how are you offering such a low rate for a knee replacement? And he looked at me across the table and he said, Dan, it's easy. There's no patients in that network, so they can offer any rate that they want. But it starts to fall apart when you actually get patients in the network. When there starts to be spend from that hospital, the hospital's not nearly as generous. So I always caution employers to be really careful with new networks. because new networks will often offer that lower rate that honestly doesn't last long. It's not something that can mature and grow with your workforce. And since displacing your workers into different networks over time can be disruptive, you want to be careful not to jump into a new network without something that you see that's going to be a long term play. The second thing that I often hear from employers is that, well, wait a minute, Dan. They walked up and said they're only going to pay Medicare rates. In fact, they don't even execute contracts with the doctors and the hospitals. I think this is a dangerous game. I've said this for decades. It's not nothing new. I think it's actually stupid because what it actually does is it puts the patient in the middle of a very challenging situation. So let me tell you how this works. You don't build a network, but you put something together that says this is the group of hospitals we're going to work with. Your employee ends up going to one of these hospitals. You don't have a contract. They get a huge bill, but instead of actually paying the bill, the person or carrier, whoever you're working with, I hate to call them a carrier, actually just writes a check for the Medicare rate for that particular employee. Well, the problem is the hospital says, well, wait a minute, that's not the rate. We want more because that's our Medicare rate. That's not our listed rate. And so what happens is they sue the employee. Now, most of these companies will have, trial lawyers or litigation specialists that will get involved and they'll negotiate something out. And theoretically, it could be less than what you would pay if you were negotiating a contract with, say, Blue Cross or Aetna or United. But in many, many cases, this is more complicated. Now, back in the old days, when again, there were no employees within these networks, the hospitals were pretty liberal. They'd let you get away with it. But the challenge is, again, when you start to get more employees, more volume within the network, well, the hospitals and the physician groups are going to take a much harder stance in something like that. The next one has to do is that if networks grow in numbers, the cost of care goes up. What I mean by that is that network actually starts to grow. It starts to eat into the margin of the hospital or the physician group, and they're not going to be as tolerant of a lower rate. And in fact, it becomes much more difficult to get that lower rate in the future because of leverage and contracting, but also just because it becomes a bigger volume of patients within that actual facility. And then the final thing is that I often hear, well, this actual network that we're contracting with, it has a quality program or a value-based care program or a word that I just hate to use anymore. I guess it's an acronym, an ACO. And that is, I don't believe these actually control cost if they're embedded in a high cost system of care. So I often tell employers, don't really bet on the come here on a quality program as part of a new network build. You need to actually engage in a program that's actually part of a total value picture, meaning that the contract is actually a good value from a cost standpoint and they've got quality programs on top. So these are the reasons that I usually tell employers that building their own network is really, really difficult. The first one has to do with insufficient scale and leverage. You may be a big company, you may have a lot of employees, but in general, most of the time, these employees are dispersed over a very wide geography. And typically in today's healthcare market, hospitals serve a regional geography, physician groups serve a regional geography. So if your employees are dispersed over a pretty wide area, you really don't have the kind of scale and leverage that can actually help you in negotiating a contract, particularly one that can be done long term. So that's probably one of the biggest reasons that you need to be careful going into this market is you may think of yourself bigger than you actually are. The second thing is something that I'm not going to go into great detail here, but I'm sure you've heard of it, things called most favored nation statutes. Many of these providers and hospitals are going to have provisions in their contracts, maybe not called out directly, but basically what they're saying is to the big carriers, we're going to offer you a better deal than we'll offer anyone else. And that means that an employer may get what looks like on the surface a better rate, but in reality, it's probably not because they're contractually bound to actually give the better rate to the carrier. The next issue has to do with actually designing a network and maintaining it. It's really a full-time business. And in fact, in most insurance companies, particularly the larger ones, this significant part of the budget is in network. Building a network, getting the contracts done, making sure the quality and credentialing is done. It's really a full-time business and a full-time job. It's not something that's just easily outsourced. Now, I will say that that is changing, and I'm starting to see some new startups actually pop up. Some of them aren't quite so new that tackle some of these really hard jobs, like managing quality and managing credentialing. There's a company called Verifiable that actually will do credentialing now for both hospitals and for employers and everyone else. And actually, they do that through a very cool system. And it's one of those resources that typically was only done by carriers. And now you've got a company here that will actually do that on behalf of employers too. I'm going to do an entire video in the future on the whole concept of the provider directory. If there is something today that actually needs rebuilt from the ground up, it's the provider directory. Most of the time, governments and legislatures require you to build them. If they're not done correctly, then you're going to end up having to pay for something that's out of network because your information in your provider directory was wrong. And then finally, in my opinion, and again, I could be totally wrong, but I don't think I am, patients don't use them very often. And so it ends up being a resource that requires a huge amount of build to actually put it together and to maintain it. There's a huge legal risk associated with it, and it's often one that's not very useful for patients. I already mentioned about dispersion in your geographically scattered workforce, but when you start to build a network at scale, even if you're a local employer and you have all your employees kind of in one spot, your employees are going to travel out of that spot. So you're going to have a wrap network or something like that as well. And if you do have employees that are in different locations, it's just going to further deleverage any kind of contracting advantage that you might have. And the final one, which I would tell you is probably the number one reason that employers have to be cautious in direct contracting and in building your own network, and that has to do with employee backlash. Because almost certainly, when you start to go down the path of doing direct contracting, you're going to have some component of exclusion. You're going to build, I don't like to use the word narrow, but we'll call it a focus network. And you're going to build more focus around a certain group or set of providers. That's going to hopefully give you some advantage costs. It's going to hopefully help you to make it simpler to manage a contract. But the problem is your employees are going to push back because their doctor's not going to be in that network. They don't want to go to that hospital. It could be that the hospital is really, really good for, say, knee replacements and spinal surgery, but maybe obstetrics, your obstetrician is actually at a different hospital. So employee backlash can be a real big pushback in actually building your own network for your own employees. Now, there are some things going forward that I do think offer some real opportunities in actually putting together your network. And one of the biggest challenges that you have is, okay, let's just say you're going to go down the path of building a network. Who do I put in it? Or where do I start? Or how do I actually geographically and contractually put it together? Well, you have to have data. So one of the things that we've done recently is we've worked with some companies to actually say, okay, could we actually get data publicly that would actually be able to put together the network builds that would provide information to the employer to say this could actually create value. And today we've actually worked with a company called Seraph Health. They've got a fantastic data set. They have put machine learning on top of CMS contractual data. And that actually helps you to understand the cost of the physicians and hospitals within a network at scale. That data has been around for a while, but it's often very messy. It's not put together very well. Seraph has done a really good job of being able to clean that data, parse it in such a way that it can be used in AI tools to help to build networks and to look at cost. And so we've been fortunate to be able to work with that data. And I can tell you it's pretty impressive. And let me show you a few examples. One is we can use it to build maps. So we can actually look at a cost picture for doctors and hospitals for a certain procedure, and we can actually build a map. And so we can say, okay, if you're in Central Dallas, this could be the hospital collection and subset and specialty providers that we could put together to say this would offer this kind of value picture for your particular employees. So one of the great things that you can do with your data and with AI is that you're not just limited to cost data. You can actually bring in things like Google reviews, Indeed. You can bring in Glassdoor. You can bring in Yelp, things like leapfrog data, quality data, even things on social media and the news that are happening. You can collect all of that information into something that we call a knowledge graph or a semantic graph, which means that you can not only look at the cost picture of a network to actually know if doing this is a good idea from a cost standpoint, but you can get a pretty good idea on, are my employees going to be happy within this network? Does it meet all of the needs that I have related to adequacy, but also do these actual providers provide the kind of service that I would want for my employees? And we can even look at things like Glassdoor, where we can look at reviews related to employees that have both joined and are leaving a company to get an idea if the management within these facilities is strong and sustainable long term. This can be incredibly valuable in actually helping you to build that sort of network of the future. And it leverages AI and all of the data that's available to be able to put it together. So I thought I'd kind of show you an example about how this can be used. This is actually done for a client as a prospecting tool. So this was actually a broker who was going to actually go talk to an employer and say, hey, we think we could help you construct a network that would save you money in the Houston market. And so we actually helped them put this together, and we leverage the kind of data that I'm talking about. So let me kind of walk you through it so you can see exactly how this works. Now, just imagine if you're a broker and you could run something like this on a company, you could say, I'm going to pick, this pipeline company or this oil field service company or this technology company in Houston. And you're going to say, okay, we know that you're on this particular insurance network, but we think we can save you money. We're going to run an analysis proactively, and we're going to add a bunch of other stuff into it. So let me kind of show you how this works. So this is a typical kind of analysis that you can run using AI. This took somewhere on the average, I'm going to say probably about 10 minutes to put together. So it's actually not very challenging to do. So in this finding, we were able to show that Blue Cross actually beat UnitedHealthcare in this particular procedure, in this particular market, with this particular subset of employees in this geography. So don't read into that, anything bigger than that. I'm just showing you kind of an example. And it was able to look at 10 high volume procedures in that particular geography to calculate that amount. It looked at 20,000 Houston employees. It looked at 28 hospitals, 10 procedures. And again, Blue Cross was the overall winner. And it actually compared Blue Cross, Aetna, Cigna, and UnitedHealthcare, again, for these specific 10 procedures, which could vary differently. These numbers could look entirely different if you put different procedures on the list. And just to kind of show you that procedure level analysis that was done, now keep in mind this was all done with artificial intelligence. So this was not done with an algorithm. This wasn't done with some fancy Excel tool. This was basically asking a semantic query, in other words, like talking to ChatGPT, but asking it to go find and construct this data and to be able to do it from that knowledge graph. And this is actually what it was able to pick up. And you can see it got really granular. So it looked at knee replacement, which is 27447, and it looked at which one had the best rate. And I'll just show you something that's really interesting, and I always point this out to employers, is that it's almost always not peanut butter, meaning that one insurance company is not going to have the best rate in every procedure, but it's just kind of vary by different insurance companies. And you're actually really seeing that here, where in some cases, Aetna has the best rate. In some cases, UnitedHealthcare is the best rate. And then in some cases, Blue Cross has the best rate. And in actually determining whether or not this is going to be a good deal if you're an employer is going to be how many employees that you have with these particular conditions in a given year prospectively, which makes it even harder, is going to be good for your business. But I just wanted to give you a little taste of what AI can do to help you solve these kind of questions. And again, it can be pretty powerful, and it can actually come up with a recommendation. So again, this was a prospecting tool. It was not really meant to be a typical analysis, but I just wanted to show you that it is difficult to build a network. There's a lot of challenges around it, not just challenges you might think of like doing the contracts and figuring out the prices and actually contracting and getting that actual network done, but also whether or not your employees are going to be happy there and whether or not it's going to be something that is sustainable long term so that you don't have to have a lot of network disruption over time. Well, I hope you enjoyed this. I hope you can see that maybe AI can offer a little bit of insight in the future, particularly when it comes to building networks. It's not just about the contract. It's not just about the price, but it's also finding a network that your employees would be happy with long term, that's sustainable, that's got great management. If you have any questions, reach out to me. And as always, if you have topics or ideas that I could work on in the future, leave those in the comment section. I try to answer every single one. And until next time, I hope you enjoyed this.